Thank you for joining. Hopefully those of you that were able to come last week to the live conference enjoyed the back and forth with primary and rheum and pulmonary. I know I learned something. I always learn something from Jessica. I'm Betsy Kirchner. I'm a nurse practitioner at the Cleveland Clinic in the Department of Rheumatology. I'm joined by Jessica Glennie, who is also a nurse practitioner at the Cleveland Clinic, but in pulmonary disease in the ILD clinic. And this is part 2 of the ILD Community Network, linking APPs with ILD experts, or linking APPs with Jessica, I guess we could call it. And this is a shorter Zoom meeting where we will just go over a couple cases, just sort of bring everything we talked about last week more into sort of the clinic and into real life. So thank you, of course, to our sponsor, Boehringer Ingelheim. We are very grateful for their willingness to let us do this unbranded educational talk. And let's jump into the first case here. I thought RA was about joints. Well, it is, but it's often about more than joints. So our first patient is LBJ. He's a 67-year-old male who has seropositive rheumatoid arthritis. Importantly, for this case, he is dual seropositive, rheumatoid factor strongly positive, CCP strongly positive. And so he's had RA for 4 years, and he comes to, we'll say, rheumatology clinic complaining of increasing fatigue and shortness of breath with mild exertion over the last 6 months. He's currently on methotrexate and adalimumab for his rheumatoid arthritis. And the question here is what features, and I apologize, my screen is a little bit blocked. I'm going to move this a little bit. What features in this history suggest a higher risk for ILD? Well, I'll just go ahead and tell you the answer since I'm the rheum person. He is a male, an older male when he was diagnosed. He wasn't diagnosed in his 20s. He was diagnosed in his 60s, and he's strongly seropositive. So all of those things sort of work against him in the ILD department. It puts him at higher risk for developing RA-related ILD. So we do the exam in the rheumatology or primary care setting, either one. We hear inspiratory crackles. His O2 sat is normal at rest, which is reassuring, but he does desaturate with walking. And his chest x-ray shows interstitial markings. So we order the PFTs and send them off to pulmonary to see our friend Jessica, where she gets the CT, which I'll let her talk a little bit about that. But I'll just touch real quick on the box at the bottom. What do the ACR Chest 2023 guidelines recommend next for suspected RA-ILD? I will just say from here, and then I'll let Jessica take over. We do use these guidelines in rheumatology. They have a very nice algorithm that sort of tells you in terms of treatment, but it's mostly, in our use, it's mostly treatment guidelines, not necessarily like next steps in diagnostic guidelines. But anyway, so now I'm going to hand over to Jessica to sort of talk about when this patient with these results lands in her clinic, what then happens?
Yeah. So there are quite a few things here that if I'm seeing this patient, I'm already a bit alarmed, about this patient and their lungs. So one is, and we've gone over a lot of these pieces last week, but one is the inspiratory crackles. When you listen to the bottom of his lungs, those inspiratory crackles are that sound that we hear with pulmonary fibrosis. And, as a primary care or as a rheumatology person, listening to your patient's lungs, really important down at the bottom, listening for those crackles. That can be a real clue, telling you, something more than, asthma is going on in this patient. And I can't tell you how many patients I've gotten from primary care that said, "Oh, my doctor heard these sounds at the bottom of the lungs," and so then went on to work me up for ILD. So it's great that this is starting to catch on a little bit more. Okay, so I'm also quite concerned with his. If I didn't have the CAT scan at this point, his PFTs and the fact that he desaturates with walking is, telling me that he is at a more advanced stage already at this point. So desaturating with walking and needing oxygen, and his FVC, which is that assessment of the lung volumes, is restricted 65%. It should be generally 80 to 100%, and the diffusion is 41%. Again, should be about 80 to 100%. So he is kind of moderately to severely impaired on his PFTs. The chest X-ray we chatted about last time is not, it can be a good test for primary care to get the ball rolling. If we see these interstitial markings, we want to go on to get HRCT. We can't assess the pattern of injury with a chest X-ray. We can't really see the fibrosis and all of the features on a chest X-ray. We absolutely need a CT. And so on the CT, we see, and again, we talked a little bit about this UIP pattern, usual interstitial pneumonia pattern. This is when you have fibrosis on the sides of the lungs, so subpleural and more towards the bottom. And you'll have these reticulations, which are kind of these little wisps on the edge of the lung, which is kind of some early fibrosis. Honeycombing is more advanced fibrosis. So this gentleman has pretty advanced disease. What do ACR chest, guidelines recommend for suspected RA-ILD? And I actually would say this is when your rheumatologist and your pulmonologist coming together, your collaboration coming together is so important, because there is not a one fits all. There is not a this, then this, then this. You have to really discuss things. I think, do we want to go into some of that now or on the next slide? I can't remember what the next slide is, but
here's the next slide.
Oh, here's the next slide. Okay.
So you confirmed the diagnosis.
Yeah. Okay. So we've confirmed the diagnosis. Our patient has rheumatoid arthritis with ILD and a UIP phenotype. Okay. So let's talk about the methotrexate, Betsy. So what do we do about this methotrexate? Why is that potentially a problem? Why are we being asked on this slide, should methotrexate be continued?
So for years, decades, there's been this belief with, some evidence behind it that there's methotrexate lung, that methotrexate can cause, this kind of interstitial lung disease, or at least cause injury to the lung, which we certainly wouldn't want on top of ILD. That has largely been debunked. But I would go on at this point, if I was talking to the patient counseling, I'd say, your RA is not well controlled. You're on dual therapy, dual DMARD therapy. It's very appropriate therapy. And it's, exactly the way we sort of do things, but it's not well controlled. And since there is even a remote, hesitation or history of methotrexate being a suspicious character, this is a good opportunity to just sort of regroup and take that question, that element out of the equation, and work together with pulmonary to find something that might control the RA better and maybe be either compatible or do double duty and help with the lungs as well.
Yeah, absolutely. I love the word like double duty, because that's what we're looking for. What will help the joints and the lungs? And it's here that because I've seen these slides and the cases, I kind of vary a little bit in what was done in this case. But, so going back to the methotrexate, it can cause pneumonitis, kind of an acute pneumonitis, inflammation in the lung. But, you shouldn't be seeing this after 4 years on the methotrexate. It should be more of an acute thing when you start the methotrexate. I think probably there was just kind of this association of people being on methotrexate, and they also had ILD because they have RA. So there was a little bit of overly concern about methotrexate. But yeah, I agree.
There was a meta-analysis just published, and it talks about how, depending on how you look at the data, some patients, it might even be interpreted as being protective against ILD if they're on methotrexate. So the jury is so out on this, except for, you're right, the acute pneumonitis part. So,
Yeah.
but in any case, in this patient, it's not working.
Yeah.
So
we can kind of regroup. So, we here we have kind of like the things that Betsy talked about: the high titer RF, the older age, male sex, and the anti-CCP positivity. Those are kind of like high risk for ILD in our RA patients. Generally, in pulmonary, I would do baseline and follow-up assessments at least every 3 months for this patient, at least at the start, until I feel comfortable that we've gotten him stabilized. That would continue if he was continuing to progress, but definitely every 3 months getting PFTs. So Spiro and DLCO is kind of our mainstay that we do every time. We might, if things are worsening, get another walk. And if things are worsening, we might get another CAT scan, but definitely seeing him and assessing symptoms and his spirometry and his diffusion capacity every 3 months while we're treating him. So we've got a lot of options of things that we could switch him to if we decided to stop the methotrexate. And so in this case, he was initiated on nintedanib. Nintedanib is an antifibrotic, an anti-scarring medication. He was continuing on some low-dose prednisone and switched to abatacept for RA control, and his methotrexate was stopped. I think in the Cleveland Clinic, we would approach this a little bit differently. So I think that, one, he's shown that his joints are not well controlled in general. He had to start Humira, adalimumab, in addition to the methotrexate to manage his joints. Methotrexate and adalimumab are not ones that we use very frequently in the treatment of ILD with rheumatoid arthritis. So I think I would be looking at starting some immunosuppression that we know helps both the lungs and the joints. And so I think at the Cleveland Clinic, we would start rituximab for this patient, especially because he's got pretty significant interstitial lung disease and he's got joints that are not, well controlled. So rituximab is definitely the next place we would go. We want to make sure that the immunosuppression is also something that's more evidence-based for helping with the lung disease. Underneath that UIP pattern, the initial cause of it is the autoimmune disease. So we want to make sure that piece is done first. I don't know. What do you think, Betsy? Have you seen, what would you think you'd usually see in this kind of a case?
Oh, I can see, where the authors of the case were going with, choosing abatacept, because it's one of the few that we know works just about as well without methotrexate as it works with. So can totally see where they're like, we want to get his RA under control. We don't want to use methotrexate, and under, other circumstances that would be reasonable. And I don't think there's anything exactly wrong with it.
No, there's
right now, but you're right.
What has been done.
There's another medicine we could use.
Yeah.
That would help both. And
so help both a little bit more. Yeah.
And this is, this is, we always, you guys see our patients and then we kind of look at you like little puppy dogs until you tell us what you want to use. And then we're like, yes, we concur.
Yeah.
And that's what we do. And I love the second bullet here though, because, we are the vaccine kings and queens over in rheumatology. We're always talking to our patients about this stuff, especially if they're going to start rituximab. So important to get his lungs protected from as much as we can. I would add on to that to make sure his Tdap had been given in the last 10 years, because we don't want him getting whooping cough, pertussis on top of everything else. But absolutely, if his RA was raging or if he was on high dose prednisone, then we might defer those vaccines. But his RA is more like smoldering, it sounds like, and he's on low dose prednisone. So we would absolutely want to get those vaccines in before he started either, any new immunosuppression, but especially rituximab.
Yeah. I mean, this isn't wrong. I mean, certainly to do that, but so the thing that we have on, started for this patient for the lungs is nintedanib, which is an antifibrotic. And, you know, in UIP, this is more, a UIP pattern is a little bit more fibrosis forward than kind of like inflammation forward that we see in other like NSIP, and has a worse prognosis. Generally, the fibrosis continues to beget more fibrosis. But we certainly, if there is progression of the fibrosis, we will add on to the immunosuppression. I think, you know, we went over the progressive pulmonary fibrosis guidelines last week. So what we have to see really to be able to start an antifibrotic based on progressive pulmonary fibrosis in a non-IPF pulmonary fibrosis patient is worsening symptoms, worsening PFTs, and or worsening CAT scan, worsening extent of fibrosis on a CAT scan in the past year. In fact, this is our first time meeting this patient, or at least we don't have any longitudinal data on him. So truly, you can't really say if it's progressive pulmonary fibrosis unless maybe we've got, you know, something in the last year from his outside person or something like that that shows us that there's progression. So I think, you know, we'd probably take the tactic of, you know, switching up the immunosuppression, whatever we kind of decide together, repeating our PFTs 3 months, 6 months, and see if, you know, maybe getting a CAT scan again after a year and seeing if there's progression. And then starting an antifibrotic if we're seeing progression on top of, you know, an adequate immunosuppression regimen.
Can I ask, are there any of our meds that we routinely use in rheumatology that you can't use nintedanib with?
No,
Okay.
I think they're
I
all
didn't think
fair
of any,
game.
but
Yeah, I can't think of any.
okay.
The only thing I would say is some of your medications, like for example, mycophenolate might cause some diarrhea or stomach upset, and nintedanib causes diarrhea.
Right.
So there are maybe some side effect type of things that to think about. Nintedanib, you have to check liver enzymes, and a lot of the immunosuppression drugs, you have to check liver enzymes. So might have to kind of think about that on top of it. But no, there's no reason you can't use nintedanib with any of those.
Excellent. All right. So here's the summary for the first case. High-risk RA patients need proactive ILD screening. I think that's sort of gently making the point that over in rheumatology, we might have missed something. We've been seeing this guy for 4 years with all these high-risk factors, but we waited until he came to us and said he was short of breath. We should have gotten an HRCT on him either at diagnosis or maybe a year into his diagnosis, just to, you know, get a baseline. And then, you know, the high-res CT and the PFTs help us identify early what you talked about with the poor prognosis with the UIP. But, you know, if it's progressive, then, you know, the antifibrotics can slow it down. And then what you also mentioned, cross-specialty care. We have to have shared decision-making. You can't just be like throwing rituximab at our patients and we're throwing abatacept at our patients and now they're horribly over immunosuppressed. So in our, you know, big tertiary care place where, you know, I can find you any day of the week, I know where to find you and vice versa. It's unlikely that's going to happen. We're all on the same EMR. But out in the community where the pulmonologist might be on one EMR and the rheumatologist on a second one, it's so important to have that open conversation, that open communication so that we don't, you know, over immunosuppress or give medicines that don't work well together.
Yeah.
Okay, case number 2. So this patient does not have RA. This patient has systemic sclerosis. She's a 56-year-old Caucasian woman with worsening dyspnea over 6 months, similar to our last patient, but she also admits to a dry cough. And we've known that she has diffuse systemic sclerosis, which we know is different than from limited, for the last 2 years. So a couple important things right off the bat. It's diffuse, and it's been 2 years into the timeline. And we know with diffuse systemic sclerosis, there's a different sort of timeline of complications than limited. But we'll get into that in a minute. You know, seeing her in rheumatology side of things, what are we looking for? We're looking for the skin thickening. We're looking for the Raynaud's. We're asking about trouble swallowing, choking episodes, all the things that go with systemic sclerosis, and hopefully asking about dry cough and shortness of breath. And I don't usually ask patients, are you short of breath? I mean, I might, but then I might give examples as well. Like, are you having more trouble going up the stairs? You have to pause halfway up a flight of stairs. If you're carrying, something up the stairs, is it harder for you? That kind of a thing, instead of just, are you short of breath?
I like that. Yeah, that's they might say, no, I'm not short of breath, but
Yeah.
then, oh yeah, when I'm carrying something there, yeah.
They've seen great Uncle Milton on oxygen, dragging an oxygen tank around for COPD, and they're like, no, I'm not like that.
Yeah,
Like,
exactly.
so you ask more of the day-to-day stuff. And she is positive for SCL70, which we know goes along with her diagnosis. So her risk of developing ILD, I would say, is high. Would you concur?
Yeah, absolutely. So we know that, the diffuse sclerosis is more likely to develop ILD than limited. And having the positive SCL70 that's associated with that also likewise is more in line with developing ILD. And then, the timeline wise, yes, we see first those skin Raynaud's, and then the, kind of the skin stuff being kind of at the beginning of the diagnosis. And then, somewhere between maybe 2 to 5 years is when there's more risk for interstitial lung disease with these patients. So yeah, she's in that timeline. She's got the right type of scleroderma. And she's having symptoms, significant, symptoms of shortness of breath. So definitely making me concerned for ILD for this patient.
In terms of baseline screening on the rheumatology side for our systemic sclerosis patients, we typically get an echo, and if they have any sort of swallowing symptoms at all, even if they say, oh, it's only with certain foods or whatever, then we'll get an EGD and then baseline high-res CT, typically.
That's great. Yeah. Do you get PFTs usually, or at that point you're just sending them off to pulmonology to put
For
those
new
in?
diagnosis, like if they're just diagnosed and they're in, then I think we'll just pretty much get the CT. And if there's any suspicious in the CT, or if they had symptoms, then we would order PFT and send them off to you.
Yeah, I think a good thing for especially a first time you're seeing somebody that you have high suspicion of ILD, like a full set of PFTs, which is the spirometry, the lung volumes, and the diffusion capacity. And then, yeah, we've talked about that high-res CT. It gives us a lot more detail. It allows us to really see the pattern of injury in the lung and distinguish between ground glass and fibrosis and things like that so that we can make kind of a more accurate diagnosis. So really important for that high-res CT. And I'm happy to hear that my rheumatology colleagues are starting to, order those more often, and we're catching this more often. So it's really great.
Okay, so we'll assume that now she is in pulmonary and you're following her.
Yes. So, okay. So she has worsening dyspnea over 6 months, desaturation on exertion. PFT show her FVC is 71% predicted. So she's mildly restricted. Her diffusion capacity is 52%. That's kind of in a moderate impairment range. And more concerning is we are seeing downtrending from her baseline. So there is progression here. We see early honeycombing, so that's that advanced fibrosis. She also has what's called a UIP pattern, that more progressive pattern. So what are the next steps in management, and how would you initiate treatment, or would you initiate treatment or refer to transplant? Yeah, so in this patient, she is not currently on any treatment. We definitely need to get her on treatment. And similar to the case prior, we always start with our autoimmune ILD patients on making sure that they're on adequate immunosuppression first before antifibrotic. We want to hit that what's driving the fibrosis, what's driving the ILD. We need to make sure they're optimized on that. So for her, I would start immunosuppression. We know from a lot of a couple of trials, the scleroderma lung trials, that mycophenolate is a very good drug that helps to preserve FVC, forced vital capacity, in patients with scleroderma, and is helps similarly to prior use of cyclophosphamide, which has a lot more side effects. It's not inferior, I guess, to cyclophosphamide. So we start mycophenolate for our patients with scleroderma ILD. And I know even without ILD, I think they're often started for their other symptoms, their skin and things like that, on mycophenolate. Would you say that's correct, Betsy? Would you also reach for mycophenolate?
I would be surprised if this patient weren't already. I mean, this case she wasn't.
Yeah,
but she'd probably already be on mycophenolate just because she has the SCL70 and the skin symptoms. She would be coming to you
It would be
on
coming to
mycophenolate.
us already on mycophenolate.
Yeah.
Well, let's say she already is coming to us on mycophenolate. So we kind of go back to thinking about our progressive pulmonary fibrosis guidelines and our guidelines for starting antifibrotic. And we have to meet two of the three of either increase in symptoms, worsening of her PFTs, or worsening of fibrosis. Now, this doesn't tell us whether the fibrosis is worsened, but we definitely know she has worsening dyspnea and downtrending from her baseline PFTs. So she would qualify for starting nintedanib. So we would probably get her going on nintedanib at this point. Another option would be tocilizumab. That could be another option that we could start for her. But in general, yeah, we're looking to start something else to help this downtrend if she's already on mycophenolate.
And can I back up a little bit and ask you a question about both these patients had desaturation on exertion?
Yeah.
So, and very few patients come to us with just one thing. So let's just say either our gentleman with RA or this lady with systemic sclerosis, let's just say they also, smoked for 15 years in their youth and they have a little bit of maybe some COPD going on. At what point are we calling, are we worried about desaturation? If they walk and they go from 96 to 94%, what numbers should we be looking at?
Oh, that's a good question. I think I don't even sometimes think about, people outside of pulmonary might not know kind of when we start initiating oxygen. And so the answer is 88% or below.
Okay.
So Medicare actually has kind of set the standard for this. There were studies that were done way back when that utilized 88%, which seems a little bit random, but 88% as the cutoff for using oxygen. And so forevermore, Medicare has kind of used this 88%. So if they drop to 88% or below, we have a walk test showing that with oxygen, they come back up to 90 something percent and they are improved and staying at a good saturation, then, we can initiate oxygen, whatever that amount was that kept them, at above 88%. So
88% they get oxygen.
88% they get oxygen. But I would say, okay, if I did a walk at let's say baseline zero or something like that, and they dropped from 99% to just like 98%. They basically didn't desaturate at all. And then the next time they come in, they go from 99 to 93 or 94. I am looking at that and I'm saying, you're still not requiring oxygen, but that's something that I need to pay attention to.
Okay. So that's good for us to know that the trend for that is even important. It's not just like black and white numbers. So we should be doing these walk tests as part of our baseline screening, maybe just so you have something to go on. You're like, well, maybe they were always 94, because they smoked for 20 years. But
a baseline would be wonderful, actually. A baseline would be great to know.
Just walk them around the department. That's all.
Yeah, absolutely.
All right. Well, that's good to know.
So the other box, would you initiate treatment? Yes, absolutely. Okay. We got to get them on treatment. Would you refer to transplant? Yeah, probably. I mean, if they are a good candidate for transplant, they haven't had cancer in the last 5 years, they're not a current smoker, or haven't smoked in the last 6 months or had any nicotine products. If their kidney function is okay, if their BMI is within range that transplant wants, usually 34 or below, they are certainly a candidate for transplant because they're starting to trend in a downward direction. And if we need it, it's in our back pocket then potentially. I will say scleroderma is difficult because they have a lot of GI issues, and that sometimes is a contraindication for transplant. You don't want reflux or regurgitated food or things like that getting into the new lungs. And so they look at that very carefully in scleroderma patients.
That's tough.
Yeah.
Okay, so well, look, you had your crystal ball. You guessed right. They started mycophenolate on this patient. They were referred to transplant for consideration. We got on the vaccines, of course, and introduced palliative care. Okay. Is that what you would do?
I should do it more often earlier on. I mean, anybody with a chronic disease can be sent over to palliative care to just get information on advanced directives, on living will, on symptom management, things like that. I probably, I maybe I would hold back a little bit. I also don't want to scare my patient too much. We haven't even really started any therapy for her yet to see if maybe we can stabilize this. And I'm already sending her to transplant clinic and palliative care. So I might really just see how, some people come in and they want all the information, all the different things available, and we can talk about all that kind of stuff. And sometimes it's a little too much for people. You have to do a couple things at a time.
Yeah, I can imagine that conversation when, she got home that night. Well, how'd your appointment go, Mom? Well, they sent me to the transplant team in hospice.
Yeah.
It's not hospice, but that's what patients think.
That is what they think. So, yeah.
Yeah, I agree. Maybe the second or third visit, we just gradually introduce these things.
Yeah.
And give them a little hope in the beginning. We have treatments. We have medications that can slow this down.
I'll be honest with you, even transplant, I probably wouldn't at this point because we don't even have her initiated on mycophenolate at this point. I mean, I think let's get on treatment. Let's see if we can stabilize this before I, start. Now, if this is an IPF patient, it might be a little different. They're a bit more progressive. If I'm seeing a bit of progression, it might just be good to get you over. But we can sometimes get things stabilized with a scleroderma patient. So, yeah.
So all these things very appropriate. They're the things you do, the things most pulmonary specialists do, just maybe not on day one.
Yeah. Okay. I want my patient to actually come back.
Yeah. Okay. Now, how about the non-pharmacologic interventions? What can you tell these patients that's going to help them either be more comfortable or have a better quality of life?
Yeah. So we've already done the vaccines, super important. And we've done the palliative care. Yeah, that's very important as well. I don't mean to poo-poo that. That's really important too. But I think for this patient right now, the really important things are oxygen. She's desaturating and she may need, oxygen to keep her saturations 88% or above while she's exerting, maybe even, I can't remember if she had desaturation at rest, but yeah, we need to get her set up with oxygen. We certainly know that desaturations and certainly desaturations for longer periods of time can put you at higher risk of pulmonary hypertension as well, which patients with scleroderma already have some predisposition to pulmonary hypertension. So we don't want that. So keeping her treated with oxygen. And then pulmonary rehab is super important. We love pulmonary rehab. It's a one thing sometimes I can offer my patient to actually make them feel better. It really does help with their symptoms of dyspnea and fatigue, getting them in better cardiovascular fitness, getting all the muscles around their lungs, the muscles in their arms and legs, much more strong so that they can exert for longer, they can feel a little less dyspneic. And then pulmonary rehab also teaches lots of things. It does stretching, it does strength training, it teaches them about nutrition, teaches them how to pace themselves, teaches them breathing exercises, things like that. And it's kind of like a little support group. So we always try and get our patients sent over to pulmonary rehab to help with their quality of life.
That's fantastic.
Yeah.
And then what about, we know there's a range for mycophenolate dosing. How do you what makes you say, let's bring this, increase, let's decrease, what
Yeah.
do you look for there?
Yeah. I would say in general, for all ILD patients, we push them up to 3 grams daily of mycophenolate, the max dose. Interstitial lung disease is, really serious. It, certainly with like when we're doing prednisone, it takes a little bit higher anti-inflammatory, with prednisone to get things under control. So we kind of take the same tactic with the immunosuppressants. So we usually push them up to 3 grams.
Do you do like labs every three? I mean, when you initiate, obviously you get labs
More
first
often.
few weeks and everything, but after
months.
they're on a stable dose, every 3 months?
3 months, 3 months for labs, especially that blood counts. We can adjust down if things are going really well over the course of many years. They're stable. We can see if we can bring them down a little bit, or if they're having a lot of side effects, of course, then sometimes we have to adjust therapy or change therapy for that.
And if you threw nintedanib or another, any other adjunct medicine on top of it, then you'd go back to the frequent labs for a little bit.
Yeah.
Okay.
So nintedanib, we don't have to worry about the blood counts for that, but the liver enzymes. So we're going back to doing monthly liver enzymes, monthly times 3 for the liver enzymes after they start the nintedanib, and then after that, about every 3 months.
Okay.
Yeah.
All right, you want to take us out with this summary?
Yeah. So recognizing high-risk ILD and diffuse systemic sclerosis patients is important. So, the patients that have that diffuse skin tightening, proximal to the elbows and the knees, that have that SCL70 antibody are more likely to develop ILD, and more so as it gets on a few years in their disease after diagnosis, maybe 2 to 5 years. It's important to recognize progressive fibrosing ILD early so that we can get them on proper treatment, because medications like nintedanib can decrease progression of their fibrosis. Initiating proper immunomodulator therapy and timing of antifibrotic therapy is important. So generally starting with immunosuppressant medications, making sure that's optimized. And then if they continue progressing with their fibrosis, then an antifibrotic. And then we kind of talked about the timing of all of these too, with the antifibrotics and the transplant.